Thank you so much, Professor Retrouvey, for the excellent presentation. And I think your presentation just inspired so many doctors, dentists, and attendants for the futures of the treatment. And the next one, we will go for the panelist discussion. The first one, I would like to invite Professor Ko for sharing your thoughts and experiences about this topic. Thank you.
Yeah. Really appreciate Dr. Retrouvey for your excellent presentation and your comprehensive review of how the AI can be applied in clinical practice of orthodontics. And you have covered so many parts from the diagnosis and also the simulation. I think the 3D application enhance the application of AI in clinical use. That is remarkable. But for an orthodontic, I think the treatment plan is the most important part because it is the brain that cannot be totally replaced by robotics at all. So I would like to ask you that given the variability in patients' anatomy and treatment response, how do you foresee AI helping to create more personalized predictive treatment plans for orthodontic patients? And how accurate can AI models be in anticipating long-term outcomes? Can you give us some comments about that?
Yes. So I work also with 3D companies now, because as I told you, unfortunately, the academic field is a little bit not able to provide us with that speed or pace of change. And what is really interesting, especially for aligner treatment, at the moment, I stopped working with DIBS AI because I'm not in Kansas City anymore. But what I'm looking at is basically what they do, as you said so well. First of all, the diagnosis, what they do, they reverse engineer everything. So they have a malocclusion, they will correct it virtually, immediately, and then look at how can I get there with the machine. And every time they have one possibility of using AI, which is automating the tooth movement, as I showed you, well, they do it. And they basically know very well that not all malocclusions can work. But at the moment, they're pretty good at, I would say, moderate malocclusion. That's a class 1 non-extraction with some IPR. The AI is really good at this. We can predict it almost as good as a clinician. As soon as you go into higher, because you have to understand the AI works really well in the middle where the data set is massively. So as soon as you go to a cleft palate case or to a surgical case, it becomes a little bit off because it's not trained correctly. AI works only if it's trained on large data sets. It doesn't do well on one patient at a time. It's not what it does. So to be frank with you, I think the diagnosis will help us. Then you go to prediction, and then you go to implementation. So I think at the moment, we're pretty darn good at diagnosis, extraction, non-extraction, recognition of malocclusion. The AI can do it. Small malocclusions, pretty good at correcting them. And that's pretty much it. We're done with that. The rest needs to be, and again, what I forgot to tell you is AI is, to me, is assisted intelligence with a clinical experience. You need the clinical experience because AI cannot do it for you. It's not going to happen. Okay? I don't know if I answered your questions correctly, but yeah. I tried.
Yeah, thank you. Thank you for your nice feedback. Thank you.
And the next one, I would like to invite Professor Dr. Sama to share your thoughts and experience on this topic.
Yeah, so I have a question to. I have a question to ask as well.
Yeah, go.
Yes, this is Dr. Samira Kiran, and I wanted to ask, what do you think about the precision of AI when we are making orthodontic appliances, for example? You're saying that it may be applicable. So do you have any data that can show us how precise this is? And what about the concern that revolves around employment? Like, what if AI replaces our jobs? As you know, this is also a concern. And what about the precision? If you could talk about the precision in making orthodontical appliances from AI. Do you have any data about that?
Not yet, because the fabrication, as I told you, we basically, a lot of aligner companies work on that. As my own experience, we use Dibs AI quite a lot in Kansas City. We tried also Unitech, I think, I don't remember the name of the system, what claimed to use AI. We tried ULabs AI. We tried a lot. Right now, I was working with Archform AI. At the moment, to be frank with you, there is no significant refereed research published that proves that AI-driven fabrication of appliances is a lot better than the experienced clinician can provide. Okay. Having said that, a lot of orthodontics is provided by non-professionals, unfortunately, as you all know, and then AI is better. So where a lot of companies now are using, unfortunately, AI to kind of sell their products to people who have less experience and then claim that the AI will be at least as good as an average orthodontist, I would say, whatever you want to call this. So this is a bit of a concern for me, to be frank with you. But I don't own the laws. I can't tell them not to do it. That's called the marketplace it is what it is. So I think at the moment, for classification, we are working on computer vision. It's amazing. I'm doing some TMJ research. Actually, AI is more thorough than an average clinician because it will not, what you have to understand, it will not look past what you've trained the machine to do, which is something that people don't understand. If the machine is trained to look at the TMJ, patient could have a cancer in the eye, it will not pick it up, that the clinician would. So you have to be very careful with that. AI does very specific things very well if it's trained correctly. It has no, how can I say, general intelligence that a clinician will look at a piece of anatomy and say, wait a minute, this is not normal on the other side. Maybe I should do something about that. The computer won't do that. So it's very complex. You got to be careful with that. And the fabrication of appliances, in my opinion, is still not there yet. We still need to work at this. And the problem you have also is, as you all know, as orthodontists, there are so many variables on so many patients, socially, hygiene, growth, all these that are not really well covered. And the main one, which I'm working on at the moment, is called bone remodeling, because as you all know, the bone remodels, when you talk to companies, they don't have a clue what to do with that. So the AI has to go towards bone remodeling if we are going to be improving orthodontics as an AI discipline, call it the way you want, in the future. At the moment, no one's studying this at the AI level, which is unfortunate.
All right. Thank you very much.
No problem.
Yeah, so I would really like to thank you, Dr. Retrouvey, for your comprehensive, very informative demonstration of how AI can be really applied into clinical practices, and also by showing us short videos of how we really can apply these things. So I'm really grateful for being one of the attendees of this very informative webinar. I think that you mentioned about that we now can print the NAM appliance using directly printed aligner, and I think that this is already an ongoing research, and I have a colleague of mine who already printed it, and he's finding a lot of success in comparison to the normal printing, because at first it can be put in hot water, so the stents that are put in the nasal airway are at first soft, and so it's better tolerated by the babies, and then after time it hardens, so it lifts up the the nares. So I think it's going to be like gaining a lot of interest in the very near future. So I just wanted to highlight this. Also about I was so much interested also by printing the prototypes for canine impactions, because I also think that there was a research that was published and the participants reported better imagination and biomechanical applications, that when they printed the prototype of the impacted canine, they could imagine more, or they can see what exactly the mechanics that they need to apply before they can do it clinically, and therefore decreasing the side effects that sometimes we can do if we cannot really see where the canines are. Lastly, I just want to highlight that also these AI applications are going to be of great benefit when we are interacting with the different specialties. So if like perio ortho, restorative ortho, if we're having these printed prototypes or these simulations, it can make the communication between the different specialties really more effective and comprehensive. Yeah, so I would really like to thank you so much.
Yeah, that's it. It's called a virtual patient. You can
Yeah.
share it, do what you want.
Yeah.
No, and
Yeah.
I didn't present that because it's another lecture, the prosto perio. We did that with endo, we did that with perio at Kansas City, and it does absolutely work. So what we share the same file. So then everybody plays, because I call this play. Everybody takes whatever they want. We have meetings, and the big advantage is you can save it, you know, test 1, test 2, test 3. You can extract premolars. I can do this, I can do that, until you get, and biomechanically, that's why I started with impacted canines when I was there, because it's the most, as you say, frustrating orthodontic part we do at the dental-alveolar level. I'm not talking about surgery. And that's why I had so many issues. I said, we got to do better than that. And then I forced my residents to do all their treatments before this, on the computer, before they started it. And at the end, at the beginning, they didn't like it. And at the end, they all did it, because then they were printing stuff. And that's why I can show you all these pictures, because this is done by residents. They all printed stuff all the time because they liked it. Say, oh, now I understand what I need to do. So you're right. It's a very interesting application. And it comes from prediction instead of reaction. When we do impacted canines, it's called reactive. We look every month, say, oops, it's not going well. I got to change this. My way is prediction. And again, it doesn't work perfect every time, but when you predict, it's a bit better than when you react. So thank you for your compliment. I appreciate it.
Thank you so much, Doctor. Thank you.
No problem.
Thank you, both of you. And next one, I would like to invite Professor Trang Ho to share your thoughts and experiences on this topic.
Okay. Firstly, I want to say thank you, Dr. Jean-Marc Retrouvey, with the great presentations about AI in orthodontics, in application in orthodontics. I have one questions about impacted canines. So, okay. I know that you do a lot of job before you can have the model for impacted canine. So you use a segmental for separate the tooth from the alveolar, from the comicity. And can you show us which software you use for doing that? Because we know that many software in the market.
Yeah.
Yeah.
Very good question. Yes. So what I started was called DiagnoCat. What was the first one was DiagnoCat. Then I switched to Relu, not because I have shares in the company, because they're nice and we're doing a lot of good work. So Relu, now what you do, it's very simple. You take the cone beam, you import it into the Relu environment. And then after 5 or 10 minutes, I don't remember, they'll send you a message saying that segmentation is done. You also can take your intraoral scans and put them in. You don't have to, but I do it. So then they fuse everything, which I showed you. And then the problem you have is now it's nice. You have the canine, you have everything in 3D space working well. The problem is now, what do I do biomechanically? And that's the weakness of my system, is now I have to put it into what we call an open source software. It's not an orthodontic software where I do the manipulation myself. So there is no yet, there is none like I don't know, Invisalign or ULab that will do, okay, do this, do this, do this, and do the calculations for you. So I use it into a called Blender, which is a animation software for actually multimedia games. And I play a game with the canine, basically. So this is not yet, I would say, automated, but this is what I showed you. That's what I do. I calculate everything, and then a friend of mine who is an engineer calculates the robotics necessary, which is not really robotics. It's more how to fabricate the appliances to get the best possible treatment result. Because I think impacted canines, as I told Dr. Samir, is still not, I would say, a good, we don't approach impacted canines in the best possible way because it's hard to do. So when you see it before and you can simulate it, you can fabricate. My dream is to have a robot to do the bending for me, because then it'd be bent perfectly. At the moment, it's still not there, to be frank with you. We need to work at it. So
Yes.
I got
Yeah.
half the thing is done, more than half, but the second half will take a bit of time, I guess, because impacted canines are a small problem in the world of medicine, and the robot companies are not super interested to invest in that, unfortunately. But it is maybe a school can take this project and do a good job of it.
Yeah, thank you. But can you define the center of resistance of each
Yes.
tooth?
Yeah, that's what I have another lecture on that, where we do all the center resistance with my friend Juan. We define everything, we do the calculations, and we do, let's say, for teaching canine retraction, whatever you want to do, we have all these calculations are coming. It will be hopefully there in about less than a year. So then we can calculate depending on the length of the tooth, which is given to you by the cone beam. So you know the length of the tooth, you know everything. You know the perio support, then you can calculate the moment to force ratio, and you can calculate exactly what needs to be done. Again, then the clinician takes it over and applies this technology to the need of the patient and to their experiences. It's not there yet, but within a year we should be there.
Thank you. Thank you.
No problem.
Thank you, both of you. And the next one, we will go for the Q&A from the audience. And this session, there are so many questions. So I will pick up some of the question. And for all question that you ask, I will send to Professor Retrouvey, and he will answer all later. So the first one, I would like to ask the question from Dr. Muhammad. He asked, could you please share the size of the company doing the segmentation you are working with now?
Yeah, I'll put it, it's very simple. The one I use the most, and again, I feel bad, but I'll tell you, I use two. One is called 3dslicer.org, and you have to have the 5.7. And I could, if you want, I could make a list and send it to you for them, because there are some specific things. But the most important one at the moment, if you want to do it quickly, fast, and nice, I actually referred a whole company to one yesterday. It's called Relu, RELU.eu. That's it, www.relu.eu. I don't have any shares in the company. I love them because they keep on improving, and there are others. Yeah, but this one is the one I prefer. Doesn't mean the other ones are not good. They just asked me for one. This one works really well. So relu.eu. And if you have a problem, let me know, and I will definitely be more than happy to refer you to them.
Yeah, I heard so many specialists recommend the Leilu as well.
Yes, it's very good.
Everyone just love this program. And
yes,
yeah. And the next question is from Dr. Jan Carlo. He asked, can AI learn enough to be used to invent another system self-orthodontic by itself? Is this possible?
Yes and no. It's got two problems. One is our data sets. Until schools can get all their cases together, the problem, if you read any research project, it's always 100 patients, 42 patients, 62 patients. We need thousands. So that's one of the problems we have in orthodontics. We haven't been like medicine now. They all have collaboration because they understand AI, so they share their data. Universities don't in orthodontics. It's a big problem. So we have like the growth series from the AOF, which is one of the good ones. So until we have these massive databases, we cannot really train the computers really well. And if we do supervised learning for one task in particular, like impacted canine, if we want to go to neural networks, unsupervised learning, then we need even more data because then the computer has to figure it out by itself. So it becomes very complicated. So I would say no. The second problem is we have two different issues. One is every patient is different. They grow differently. They react differently psychologically to treatment. They have different parents. So that's a problem. And the second problem is every single orthodontist in the world thinks that his technique is the best and will not change. So that's a second problem. So AI, you have to open your mind to a different way of thinking where you're going to base your treatment more on data and not so much on experience. Because a lot of people you talk to conferences say, oh, I do it this way because it's better. They don't have any proof it is. They just got better at it because they practice it. So AI changes the game a lot. So, but it doesn't mean what we do is bad. It's not super compatible with AI yet at the clinical level. That's what I'm saying.
Oh, thank you. And the next question is from Dr. Andy. He asked, how reliable for AI in auto segmentation? Is any situation auto segmentations is not working?
Yes, very good. I played with Relu 4 or 5 years ago. It was really fun because I started sending them very simple cases. And the segmentation, there's a paper from a friend of mine, Dr. Dot from Paris, that looked at 4 different software. And I also reviewed one I didn't like because the problem you have is if you take, let's say, I don't know, 20 to 30-year-old patients, and you teach a computer to segment, and it will be very good at it. And then you plug an 8-year-old kid with like primary teeth and this and that, and the computer gets completely crazy because he never seen primary teeth. It doesn't know what to do with them. So the segmentation gets completely off. So you have to train the computer for primary or mixed dentition. Then you say, okay, fine, I'm very happy. You put a patient with impacted canines, the computer gets, again, oops, what's this? I've never seen that before, gets confused again. And then you do cleft palate, it's even worse. So they're getting better. That's why I like Relu. I feel bad to talk about this company all the time because every time I send them complex cases, they took the time with the engineers to teach the machine to recognize this particular problem. So you have to be careful because, again, every patient is different. If you start with a simple patient, it's fairly now simple and predictable for any company to segment correctly. But if you send them, a craniofacial patient, the computer may say, wait a minute, what is this? It's going to be very complex so it all depends on the power of the algorithms and how well the machine is trained. At the moment, I would say Relu and DiagnoCat and CEFX are pretty darn good to segment any conventional orthodontic case.
Thank you. And the next one, I would like to ask a question from Dr. Muhammad. He asked about are you aware of any automations of distractor during DO, distraction osteogenesis, or even for expander, such as doing maxillary expansion? So would not worry if patient cannot keep doing it timely or lack of ability to do it. So I think it might be about the file software when you do simulations.
Well, you have to be careful, simulation is a simulation. Simulation is a mathematical calculations of probability. It takes a data set and calculates probabilities of what's going to happen. So the more complex the question is, the more off the computer may be. All right. So what you may want to, what I think I understood about the question is, can you predict if, let's say you do a maxillary expansion with a MARPI, if you can predict that the expansion will be exactly what you expect it to be? And my answer is maybe. If the patient falls within, let's say, 20 to 25 years old, has normal bone, then probably you're going to be at 80, 90%. If the patient is 51 years old, Asperio or whatever, you may end up at being at 42%. So you have to be careful that AI will give you only probabilities, and the more you are within the, I would say, the one standard deviation of the data set, which is the mean, the closer you are for a great prediction. The more you go towards the bell curve, the right or the left, the least power the computer has. And it's a problem because many times you would like it to predict a very complicated situation because you don't know what to do with it, and the computer doesn't either. So you have to be careful with that. The computers are great when they are trained. Right now, we use 90% of what we use is supervised learning. We train the computer to do a specific task called machine learning. It's not just putting a patient in there and say, tell me what to do. This is never going to happen. You still need the experienced clinician to work with the data.
Thank you so much. Because lots of the questions, so like we will send all the questions to you. And may I ask, like, can we share your email to all participants? Because I think maybe they want to write email directly to you to ask a question.
No, you can share that. I have no problem because I like to answer questions because it's a new field. People have very interesting questions. And to be frank with you, sometimes I learn a lot from the questions because I say, oh, I didn't think of that, and then I need to research it because I usually, like last week, we ended up doing a very cool appliance, which is here. And it happened by accident because I was talking to an engineer and then we started to play with questions and we decided we disagreed on everything, and then he printed it and then he said, well, you were half right, and then we discussed it. So I learned a lot actually from these questions because at the beginning we were not at all on the same wavelength, and all of a sudden it got so much better. So I don't mind questions if it's related to AI or orthodontics. Don't ask me any other questions. I will not respond.
Okay. And the next one, I think we will go for the announcement from Singapore, like the neighborhoods of us. And thank you again for Professor Retrouvey for your presentations and like all answering in the Q&A. So we go for the next sessions. Thank you.
Sure. Thank you very much. Can I leave now or what do we
No,
do?
just stay and we're gonna have the group photo later.
Okay, it's good. Thank you.
And the next one, I would like to introduce the meeting from Singapore AOSC, Association of Orthodontists, Singapore Congress. Dr. Enrica just shared me and would like to invite those of you to join the conference this year. It's going to be at the end of February. That will be like pre-congress and the congress and the post-congress conference. So the main conference, it will be on the 1st to 2nd of March. And like this conference is gonna take like 4 days. They're gonna be the pre-congress and also the post-congress. That will be the pre-congress forum, like Women in Orthodontics. The session title is Oral Condition Related to the Female Patients and Management by Dr. Chelsea Sim, and the post-congress will be the workshop from Dr. Senda Tai. I think if anyone just would like to know about the kid patients in the mixed dentition or even a listener, like she very famous on that topic, and she gonna give the presentations on the topics of complex cases with aligner technique, the good, bad, and the ugly, borderline extraction cases, and impacted canine. And the registration is still open. You can capture the QR code or even go to the website aos.congress.com for the further information. And thank you for all of you. So Dr. Cho, please like invite everyone for the group photos.
Thank you, Prior, for your introduction of the Singapore's Congress. First of all, I have to appreciate the Professor Retrouvey for your very excellent presentation and you share very, very updated AI application in orthodontics works. And then really we have very, very excellent three panelists, including Professor Cole, Professor Ho, and Adele. And we have a lot and a lot of questions. We have no more time to answer all of your demand, but very, very nicely, Professor Jun already provided his own email in our chat room. So please refer to there. If you have any question, you can directly to contact with the Professor Retrouvey for your answer. Yeah, so it's time to have a group photo, and I would like to invite all our audience of ICC today. Please show us your very big smile, and we can have a group photo. And please turn on your screen. And especially thank you, Professor Retrouvey, get up so early to give us a very nice presentation. Yes.
Can I do something in the chat? Yeah. In the chat, it's Relu. It's R-E, like
please.
Emil, not R-A. It's R-E-L-U. Please correct.
Okay, R-E-L-U. R-E-L-U. Sure. And finally, Prior will collect the relative information, including the software and professor's email in our announcement in the Facebook as well. So once you have interest in, please add yourself in our Facebook, the society. Yes. So I will count to 3 and please choose. Okay, and we can take a photo. So now 1, 2, cheese. Okay, thank you very much, all my friend in ICC. So good morning and good evening, and thank you, Professor Retrouvey again, and thank you all our panelists. And actually, the following 2 weeks, we have 2 more the ICC webinar. I have to introduce the Sunday. The topic is the orthodontic surgery combined with the facelift and the rhinoplasty, and spoken by the Professor Yama-chan from Japan. And 2 weeks later, we have 1 more topic, very interesting one, that is the microtia reconstruction from the Professor Renick from United States. So please join these 2 more webinar with us. Thank you very much. Thank you. Bye-bye. Thank you, Professor Retrouvey. Thank you.
Thank you. Thank you.
Thank you, Professor Cole. Thank you, Ho. Thank you, Dr. Adele. Thank you, Professor Handa. Thank you, Anoop. Thank you, KK. Happy New Year.
Happy New Year.
Thank you. Thank you, Prior. 谢谢柯医师. Okay, thank you, Prior. Thank you, Professor Ho.
Yeah, thank you.
Thank you very much. So Prior, probably you can collect all the question in our chat room.
I did already, and then I'll send Prior the Word document. I saved it on Word, so I'll send it to you in a few minutes.
Okay. Sounds great. Okay. And I will record the video and soon later upload to the YouTube, and I can give the Prior all the photos I captured in this presentation. Okay, thank you very much. Good evening, good night. Bye-bye.